Hi, everyone. TJ Aulds, I45 Now. Welcome back to the Thanksgiving edition of our weekly COVID-19 updates as we take a look at things of how they're affecting in Galveston County. And is joining us every Monday, as he does at this time, is Dr. Philip Keiser. He is the local health authority for Galveston County. He is also an infectious disease expert and joins us every week to discuss COVID-19 and its impact on us as we resume these, as we start to see the upward trend in cases, as we expected as we get into the fall. And as we, right now, Dr. Keiser, as we take a look at the charts, so we'll be looking at today, we do have a report that came out over the weekend. Obviously, we had 2 more deaths after having absolutely no deaths related to COVID-19 for the most part. For a long while, the month of November, we've had 6 total, 2 that were reported on Saturday. And you said that's not really unexpected from what we've been seeing trend-wise.
Yeah. No, that's absolutely right. I mean, we've been seeing our numbers creep up slowly since the middle of September. And so just keep in mind that the number of cases is followed by the number of people who end up in the hospital by about 2 to 3 weeks, and then people tend to die several weeks after that if they are going to die. So this can be a very prolonged illness. So it's not surprising that as we see our cases number creep up, we had a very good October. For the longest time, we didn't have any additional deaths reported, and we started off in November with about 152 deaths on the books. And we've had 6 more since then. A couple of them were from October that have just taken a while to get reported, but now we're getting some that are fairly recent. So, this is all predictable. As we see more people get infected, we're going to see more people get hospitalized and more people die. We're seeing our hospitalization rates go up. We're seeing, beginning to see more people die.
One of the things that look at the latest deaths, both women. One woman was between 61 and 70 years of age, and the other 71 to 80 years of age. Neither one was a nursing home or assisted living center resident, according to the data here. And we're taking a look at deaths by age. If you look at those 2 age brackets alone, 22% of those who have passed away in Galveston County were within that 61 to 70 age. The 71 to 80 range about right at 25% in that range there. And again, these weren't assisted living or nursing home, but they did have underlying conditions. And that is the one thing I think a lot of folks may not understand, is that in almost every one of these cases, there's been some type of underlying health condition that already exists that the COVID-19 attributed to the death, contributed to the death. Can you explain that a little bit more? I know we've talked about that several times, but so that folks understand, just because someone has COVID doesn't mean it's a COVID-related death. Can you explain how that actually is classified? It's not willy-nilly just based on a positive test, correct?
Yes. So basically, what we look at is we look at death by COVID, not death with COVID. So, for example, what would death be COVID be? You're 19 years old. You go out and you catch COVID. You have a positive test, and then you go out and get hit by a car. Okay, that's not death by COVID. That's death with COVID. So believe it or not, that doesn't happen that often. And what we're really looking for are people that have that are sick, that have symptoms that are consistent with COVID, and that have a death that's consistent with dying from COVID. That's what we do. We see all of the reports that come, not just the death certificates, but the medical records. And occasionally I am asked to actually review a medical record to see whether this really was someone who died from COVID. We had an elderly man who hit his head and died from that, but also was found to have COVID incidentally, and that's not a death from COVID. So we do our best not to count those, because we want to give people an accurate picture of what's really happening with this infection.
And even if it's a respiratory illness that someone has as an underlying condition or something like that, as I understand it, the way it's looked at is that if this person should still be living with this condition, what would normally be a chronic underlying condition, versus an acute one, that if COVID attributed to that death significantly, that's when that call is made, correct?
Yeah, and a lot of times these are judgment calls. I mean, that's the thing you have to realize. So if someone has bad lungs and they get COVID and the COVID is what tips them over, we would count that as a COVID death because they wouldn't otherwise have died without that. But again, we try to distinguish that from someone who just incidentally has COVID, who was not adversely affected from it, who died from something else. And there are times when those things can get blurred. So we do our best to try and make the right call.
And forgive me there for the background noise. For that, it was we had a double feedback on there for a second there. And two is again, and I want to stress something that you've said consistently here too. By the way, too, folks, you may have seen the numbers change a little bit. What I did was I excluded the nursing home cases of deaths here. So, and you can tell, and you can see the difference here. And this is, by the way, starts in March and comes all the way through. So early on, we had a lot of cases that were related to nursing homes.
That's right.
The living centers. Now we see the trend go the other way. And that's why I think it's important to show, because we've actually seen that somewhat become manageable. And that is something because as we talk about Thanksgiving and spending time with the family, I know today, for example, we have a crew member who's going to be over at the Phoenix Care Facility in Texas City, and they're holding a little parade for folks there because a lot of family can't get in there and constantly visit their family with the COVID restrictions that they have put in place. So that time of being with family or the big meals and the stuff are going to be down, and that's why I wanted to show it because really, how are assisted living nursing homes doing right now? I know that the state's monitoring those now and not on the local end, but it seems that they have gotten more of a grasp of what needs to be done.
Yeah, no, I think they're doing a good job. So assisted living centers are now not just monitored by the state, but also by the federal government. And anytime they have a case, they have to go through and test everybody. So they're being extraordinarily aggressive in terms of their testing. And they're also being very aggressive in terms of who gets let in and who doesn't get let in. And so for the most part, places in assisted living have little contact with the outside. The rules loosened up a little bit so some family members can be allowed in for short visits. But people are being watched very, very carefully. And the good news with that is that you haven't seen all the deaths. You know, we saw most of our deaths from assisted living facilities in April and beginning part of May. And that's when we had the real big problem. But when we started putting restrictions around what people could do and what they had to do, that's really gone down. And we worked very hard with all of the nursing homes in the area to make sure that they had good procedures in place and that they understood them and that that they were things that could be executable and help them solve problems. So I think all in all, as a group, we've done a good job and we've been able to protect the most vulnerable of our elderly at this point as much as we can.
And should point out is so the numbers you're looking at here, folks, if you take a look at the number of deaths up here, that's 101. That excludes the nursing home and assisted living.
Right.
So the vast majority of the deaths have been of the 158, 101 of those have been folks not in a care facility. Most again though, underlying conditions as we had over the weekend. And we're not trying to dwell on deaths. This is the first time we've had multiple deaths in a while and wanted to get a good grasp on that because that is a concern. And then you brought up something in one of our sessions a few weeks ago that I think is important for folks to understand is that it's one thing if you take the number of positive cases and the number of people who died, that's really not the way to look at it because that's in many cases a lot of times what it is with any type of virus is that it's a lower percentage of death. It is after that. It is those who get sick enough to go to the hospital. That is when it really jumps up. And is it still holding that trend that if you go into the hospital, about 10% of the patients who end up in hospital care end up?
I don't know what the answer is right now. I can tell you we've gotten better at taking care of people when they're in the hospital. And if you look across the country, the death rate has gone down. It was worse in April. And what we're seeing, and also what we're seeing now playing in El Paso right now, is that you really get the extremely high death rates when the hospital systems get overwhelmed and they can't take care of everybody. And then the other thing, there are reports and studies coming out now that when your hospitals get in that situation, people's ability to access healthcare in other areas falls apart as well. So there's going to be there's probably going to be a spike in breast cancer among women because women couldn't get mammograms done in a timely fashion. And I expect other things will happen as we learn better what's going on. So it's very important to keep the hospitals running and running the way that they should be running. But the death rate has been falling, and we have more tools now to help us. We have, obviously we have remdesivir, but just recently, last week, a new drug came out. It was an IV antibody that's designed to kill COVID, and it seems to work best before people get really sick. It's people who have risk factors, who are symptomatic, and if you treat them, you can avoid hospitalization. So for every 20 people you treat, you avoid at least one hospitalization. And that's the first one came out last week, and the week before, and then the second one came out just a few days ago. So we're ramping up and going to start using those antibodies as well.
And that's one of the things I wanted to talk to you about, the issue with those therapies. We saw obviously kind of a conflict too. Remdesivir, which has been used widely at UTMB and been successful. The World Health Organization came out with an odd recommendation based on all the facts out there, saying, "Well, we don't recommend using that."
Right.
And I just wonder if you could answer that, because all the data we've seen local, the United States particularly, remdesivir has been highly effective, and locally we know it from the work at UTMB.
Yeah. So with remdesivir, we have two well-designed clinical studies that show if you use remdesivir, that you can reduce people's time in the hospital. That's our primary endpoint. And as we've gotten more doses of remdesivir and been able to use it with more people, what we believe the real utility of this drug is to get to people who are just sick enough to be in the hospital, and that keeps them from getting sicker, gets them out of the hospital earlier, keeps them from getting on a ventilator, and then keeps them from dying. Although we haven't formally proven that it keeps them from dying. But we've seen the death rate fall the more we use it. So I think most people believe that the drug has some utility. It's not penicillin. It's not,
right,
a wonder drug. It's something that makes things quantitatively better, which is why we're using it, and we think it has some benefit. And then the WHO did a study, but they did a study. It was all over the world. It was in over 400 hospitals that were quote unquote stressed by COVID, i.e. these things were falling apart. And again, what we know is that you're going to have a very high death rate in places where the hospitals are full and you're having a hard time keeping up. And so what I think happened in that case was they gave it to these hospitals, and the hospitals just gave it to everybody they could. And quite frankly, everything was falling apart, and they really didn't show that the drug worked. So it was probably the worst scenario in which you want to use that drug, because again, it's not a great drug, but it's a tool. So we're still going to be using remdesivir, and we still have data that says that it has a utility, and I think that's where we stand. And I think most of my colleagues look at the WHO study, and they just think it wasn't very well done, and you can't trust the information in it, and they're not going to act on it at this time.
Yeah, and I bring that up for two part. One, we know differently from what we're hearing here, but secondly, again, it becomes part of that confusing information that the public here. I think most of the time this would be just kind of handled amongst researchers and scientists for the most part, and policy wonks, but not the general public as we are now. So what we're seeing out here, it's not taken in full context. You just hear, okay, WHO says don't use it. And folks like yourselves will look at it and say, well, not really. Normally, that's the normal debate that goes on behind.
That's correct.
I don't want to say behind the scenes, because it's actually an open debate if you're really paying attention to it. But now the public is able to observe this a great deal. And so that is interesting. The other was Regeneron's COVID-19 therapeutic treatment. That was the one, quite frankly, made famous when President Trump was hospitalized for a few days. It got emergency approval over the weekend. Your
right.
thoughts on that because that showed some promise as well.
Yeah, well, I think we're going to be using it. So there's another drug very similar to it called bamlanivimab. That's a tongue twister.
Yeah.
But basically, it's a monoclonal antibody that is directed against what's called the spike protein, the part that keeps COVID from hooking into your sinuses, and it reduces the amount of virus that people have in their blood. Not a lot, but a little bit. And it helps reduce people's time of symptoms. And so it helps make them feel better. And it reduces hospitalization. And that's where we're really interested in it. And so the Regeneron product is very similar, except it has two antibodies. And it's been used in President Trump. And also Ben Carson announced that he was treated with it. And of course, Ben Carson is the director of HHS, but is also a very famous neurosurgeon from Johns Hopkins. And he said that he felt like he was going to die and that drug made him feel a lot better, and he believes it kept him from going to the hospital. So what we've been doing all last week is working very frantically to develop the protocols to handle these drugs. The problem is that they have to be given intravenously. You have to have a positive COVID test, and you have to fit into one of the risk factors. We currently have a small amount of it that was given to us. It's being allocated. And we want to get it out there and use it in people that we think will help them as quickly as we can. And we're hoping that they'll give us more, and that at some point we'll be able to make we'll get enough of it that we'll be able to make a big dent into the hospitalization rate. So all in all, it looks good. It's not simple. It's not a pill. It's not an injection. You need to come in. You need to get an infusion. You need to sit for an hour after you get your infusion. Make sure you don't have any side effects. But so far, so good. And we're looking forward to start giving it to people.
We're right now, Dr. Philip Keiser, the local health authority for Galveston County, on with us right now. And we're talking about all things COVID-19, particularly as we lead up to Thanksgiving. Taking a look at the latest data released. It was released a little over an hour ago by the Galveston County Health District. The number of active COVID-19 cases in the county now at 1,378. We had 2 more deaths. And again, this includes the nursing home cases that are out there. And as we were talking about therapeutics and the like, one of the things too is vaccines. Obviously, the great news that we've had the last couple of weeks on the vaccines, and then also AstraZeneca came in overnight and talked about that one they're working on, and it kind of jumped. It went from highly effective to around 70% or so, which is highly effective too. Then they came back and say, well, that's even more effective than we thought at first. Everyone wants to compete for that 90%, that 95%, I guess, that's come out. And again, I ask you this because 2 of those that are out, the Moderna vaccine and the Keiser vaccine, are both being tested, both being trial run at UTMB Health facilities in Galveston and one in League City. But again, if you in March, when we first hear from the WHO that this is a pandemic, and talking about our approach to things, and we get our first positive case in our area, and then from there to now, to see vaccines with that effectiveness in place, that's quite amazing. I would think in any realm. One, I don't think we've ever seen that before in the history of development of vaccines, have we?
No, we haven't. In fact, for many years, my primary job was treating people with HIV, and I can remember when I was about 28 years old, hearing the head of Health and Human Services in the United States announced that they found the cause of the HIV virus, and they expect to have a vaccine in several months. And now it's over 30 years later, and we still don't. So, so it just shows you how difficult it is to develop an effective vaccine. And I think there's really been a real tour de force of vaccine development here that's getting great results for 2 reasons. One, they use a new technology. This is what they call RNA vaccines. And they are the positives about these vaccines is that they can be developed in very, very high amounts without having to go through all of the technical difficulties of, say, developing a flu vaccine. It's actually much harder to make millions of doses of flu vaccine. So that's number one. Two, well, at least with this virus, it's developing extremely strong immune responses, and that accounts for the high rates we're seeing. And so if you look at all three of the vaccines, whether it's Pfizer's, Moderna's, or even the AstraZeneca one in one subset of patients, they were at 90% as well. Now, we don't know exactly why in one group they only got 62 and in another group they got 90. They don't know. And they're going to be looking into it and trying to figure that out. But if you just look at it, instead of thinking of it as three groups, think of it as four different groups. Pfizer's, Moderna's, and then AstraZeneca has a group where they gave a dosing schedule where everybody got 2 doses at full dose, and then another group got a half dose and then a full dose. 3 out of the 4 have greater than 90% efficacy. That's remarkable and amazing. The other thing that's really amazing about this is the distribution network, and the federal government really allowed for the development of these vaccines while they were still being tested. Again, something that's never been done before, but everyone decided it was worth the risk. And it looks like it's going to pay off. And in fact, as soon as I'm done here, we're getting on a conference call where the state's going to talk to us about pre-positioning some of these vaccines so that when they get the go-ahead from the FDA, we don't have to wait for them to be shipped. We'll have them here, and we'll just start that day or the very next day. So there's a lot that's gone into this that's worked extremely well. We've heard a lot of stories about things that haven't gone well with this pandemic, but this is one where things have gone extremely well so far.
No doubt about that. In fact, Governor Abbott, right before you and I came on, announced what's going to be kind of the priority list for getting the vaccines in the state of Texas. Obviously, first responders of frontline health workers, particularly those working with COVID-19 patients, will be the first to get the vaccine. The concern that may be for you and others, however, is that yes, you'll maybe have it ready right off the bat. Moment the announcement's made, hey, come get your vaccine. Healthcare workers, I don't think as much, but when it gets to the general population, 42%, according to the latest polls, won't take it.
Yeah, well,
to you at all, and obviously,
yeah.
Someone put it to me like this, and I had to agree to a point. It's like, someone always says, every time Apple rolls out the new iPhone, I wait till the next time, because I want them to work out all the bugs first. And I said, well, and I kind of chuckled, but then I realized, yeah, maybe that's right in some way, because this is the first rollout of a vaccine. We've seen throughout history the vaccines improve over time. But is this something, if right now, if someone walked into your office and had a syringe and was ready to give you the first dose, because you would qualify for that, would you just turn around and say, yeah, go ahead?
Oh, no, I plan on getting it. I fully plan. In fact, I want to be at the front of the line. I want to be the first one in the county that gets it. But I understand why people are reluctant to do it. Not only among general population, there are healthcare workers who look at the speed at which this has been done and look at the way that various politicians have kind of used the discussion of the vaccine, that they're sitting back and thinking, oh yeah, maybe I'll wait. Maybe I'll wait to see how it works. Maybe I'll wait 3 months or 6 months. And in some level, I understand that. But as I watch this work its way through the process, my confidence level grows. And I have yet to see anything that would make me say that I'm not willing to get that vaccine. So I'm perfectly willing to do it. You think about the numbers. So, 42% of the people say they don't want to get it. Don't think of that as a failure. Think of this more like an election. Where do we need to be? Well, we need to be somewhere around 70, 75%. So I don't need to win all 42% over. I only need to win about half of them. And then we'll get to a point where we don't need to do all the stuff that we've been doing. But even if we don't get that number, even if we only get half the population vaccinated, that's going to make a huge dent into how much this virus affects things. And I think as time goes on, more people will be willing to get vaccinated. And as time goes on, we're going to see that the cases are going to be cases of people who didn't get vaccinated. The people that get hospitalized are going to be the people that didn't get vaccinated, and the people that die are going to be the people that didn't get vaccinated. So when you put all that together, I think we'll get to where we need to be. It is going to take time. We're not going to have enough to do everybody all at once. We don't have the logistics to do, 340,000 people in the county all at once. So it is going to take time. So that some people want to wait, that's okay. But we'll work our way through them, and then we'll start talking to them once it feels like we have a party that nobody came to. We'll start talking to them.
Right. Yeah, and sometimes that's what it takes from there. And obviously, as you said, you don't, you're not surprised by, and you kind of expect it. Some folks say, I'm not so sure right off the bat. One of the things too to talk about, we had one of our Stephanie Stocksville, who's one of our viewers, asked, how about until the meantime, obviously, because it's going to be a while before the general public has access to that. How about preventative immune boosting vitamins and minerals? Is there any studies going on right now of over-the-counter type of things?
Yeah. I mean, there are various things. We honestly don't know how well they work. There's one company that's promoting an extract of what flower is it? I'm blanking now. But basically, oleander. I'm sorry. So there's an oleander extract, and then there's other extracts. I'm not going to tell people don't take those things. I would just say, look at it with caution. These things are not approved by the FDA, so we don't know what's in them. So, if you want to take something, just check with your doctor and make sure that it's not something that's going to be harmful, or more importantly, it's something that's going to interact with any medications that you're taking. And that seems to be a bigger problem with some of these food extracts and dietary supplements. The healthier you can be, obviously, the better off you will be if you get the virus.
The other question we had from one of our viewers is, and this something I know the answer always is we really don't know yet, but I just need to ask it again. Is how about someone who's already had COVID? Can they get it again? And there are some cases we're hearing where someone had COVID.
Well, there's been clear cases of people who have been reinfected, and that's been proven. Several months ago, we did not think, or we didn't know whether that could happen. Now it's been proven in probably maybe 15, 20 cases worldwide. We have about 20 plus people that we're following in Galveston County that have had 2 positive tests, separated by 3 months, separated by negative tests. And so we think that they've been reinfected. So in general, with vaccines, we don't tell people, you've been infected, therefore you can't get it. We have not received any guidance from either the manufacturer or the federal government from that. And unless people tell us not to, we probably will recommend that people get vaccinated, even if they've had COVID. And I understand that there's some people who probably think, no, I'm fine. There'll be other people who may have some long-lasting symptoms of COVID who want to wait a little bit. And I totally understand those positions as well.
Let's go into, as I said, the promise that we had AstraZeneca. One of the things interesting is that how each of these vaccines has to be stored.
Yeah.
The Pfizer vaccine has to be at whatever the super cold temperature.
Yeah. Minus 94 degrees Fahrenheit.
Yeah, and Moderna says, well, we could kind of keep it in a fridge. And I did not see the stats on AstraZeneca, but it's also it's like 2 doses and the like. I mean,
right.
This is I'm somebody asked me that. Well, why does it have to be so cold, and how do I get in my normal doctor's office if that's going to be the case?
Right.
I wonder if you can explain that so folks can get kind of a grasp of what that means.
So the Pfizer one is the one that really has to be extremely cold. All of these vaccines are made of what's called messenger RNA, which falls apart very easy at ambient temperature, so normal room temperature. So that's why it's frozen. Now the question is, how cold does it have to be? And a lot of it has to do with whatever the preservatives they put in there to try and keep the messenger RNA from falling apart. And so Moderna's is one that doesn't need to be as cold. And in fact, when you talk about the cold storage chain, it just needs a normal freezer. Okay, so it needs an industrial grade freezer, one where the temperature doesn't vary much, and you can guarantee that it doesn't thaw out like my freezer does occasionally.
Right.
But the Pfizer one.
Your home freezer. This is not.
Yes, my home freezer. Let's make that sure. Right. When I go to get ice from the ice maker, and I go, why is all the ice clumped?
Right. Yeah.
It's usually because I left the door open. But But the freezer that Pfizer requires is just, it's a little different, and all these things are a little different, and the technology may advance so that you don't need to have this ultra cold. What does this mean in terms of practicalities? It means that the Pfizer vaccine, which is going to come out first, is going to go to the hospitals and places that have ultra cold. And I think that's pretty clear. So you can look at, Pfizer's vaccine being available, say at UTMB, at the Texas Medical Center, HCA hospitals, places like that. The Moderna vaccine, that one is likely to then go to regular doctors' offices that have freezers. And so that's going to be the real key distinction. And then as the freezing requirement becomes less and less, you'll see it more widespread. Currently, we've got over 36 providers in the county that have signed up to give this vaccine. So as it becomes available, it should become available fairly widely. And we think the Moderna vaccine is about 2 weeks behind Pfizer. So we're looking at Pfizer's vaccine to get here sometime in mid-December, and Moderna sometime around the first of the year. And we don't know what's going to happen after that with the other ones, but they are going to follow in rather rapid succession. And I think we will have plenty of vaccine. Remember, Pfizer has the capability to make 1 billion vaccines by spring. Okay, so if you do the math, it takes 2 doses, that's 500 million. Half of it's going to go to Europe, half of it's going to go to the United States, 250 million doses for the United States. That's just Pfizer. That's not Moderna. That's not the other ones. There's going to be plenty of vaccine around, but it's just going to take time to get to that point. And probably the hardest part will be scheduling an appointment to get your vaccine if a lot of people want it.
Right.
Because you got to give the shot, you got to watch people for 15 minutes, make sure nothing bad happens. And use of that space just takes time and uses up resources.
The other to ask along those lines, though, is that you talked about, the vaccine, how, is that this spring and the like, and what, obviously, what do we do till then? And it's still going to be wash your hands and social distance and face coverings.
Still wear a mask, right. And after I get my vaccine, I'm going to wear a mask, and I'm going to continue to wear a mask because initially I'm not going to be protected. And there is a risk of failure. And so, at least within the healthcare facilities, even though people are immunized, we're still going to have masking in our healthcare facilities. What do people do? I would say just be very, very careful. One of the things that worries me is the way our numbers are going, is that we're looking at a pretty bleak December. Even though we're getting vaccine and we're getting new drugs, these numbers just keep increasing. We can have a lot more people sick and a lot more people dying in December if people aren't careful. And so it's very important that people don't give up and that they stick to it. CBS News had a very interesting piece this morning. They went to Sioux Falls, South Dakota, and they interviewed people walking down the street without masks. And they asked them, what do you think about masks? And the answer was, I know it helps. It'll be good for me. And some of them were going into bars, and they go, no, I know I really shouldn't. One of them was an ICU nurse. So there's a disconnect there. There's this disconnect between what people know versus what they do. And what we really need people to do is to do what they know is the right thing to do. That's the best way to protect yourself, the best way to protect your family. And don't look at it like, just throw your hands up in the air. There's no point because there's nothing I can do about it. I can't live like that. Yeah, you can. And not only can you do it, you don't have to do it for that long. We're getting the vaccine over the next 3 to 4 months. We're going to get a lot of people immunized. And so that's when people can start changing the way they're living their lives.
The one thing, though, to ask is, we just talked about, if someone who had already had COVID-19 and not necessarily are immune to that, what makes anyone think that once you get the vaccine that it doesn't wear off? I mean, that's one of the key things. It's still,
well, it might. Yeah, it might very well. And so it might wear off, 6 months later or 9 months later. We may need to get a booster shot come fall. Come flu season next year. We might be doing is saying, okay, come on and get your flu shot and your COVID booster, right? So it might end up that way. On the other hand, it might not. It might be something where people will do very well without it. And the longer time we have, the more then we have a good sense of how long this lasts. So we know immunity lasts at least 3 months. In some cases, it's lasting up to 8 months, the most recent study. So, and if you've had COVID and you get a vaccine, that may boost your immunity so that you actually are much, much less likely to get another infection.
And I wonder though too, does this become, like you said, becomes like the flu vaccine where at least the foreseeable future, we're going to be having to take this once a year, or not have to, but recommended to take this once a year.
Could very well be that. Yep.
Let's talk about Thanksgiving now. Is coming up, obviously Thursday. We've heard a lot of recommendations. Keep it local, keep it kind of a Thanksgiving bubble. If you would, when I talked beforehand, we're doing that with our families. In fact, limiting, it's just going to be me and my wife because we have extended, we have our family members, our older family members who have pre-existing conditions, and that's one of the things we have to be careful of, particularly since we're out in the public so much. And you're doing similar thing with yourself and your family. And is that just really, folks, this is the first kind of big holiday everyone gets to get out and enjoy their time after being, for the lack of a better term, cooped up and not being able to travel around and the like. What do you say to those folks that say, listen, darn it, I want to go see grandma?
Please don't do that to grandma. I mean, that's the reality of it, is that we've heard a lot of different things, right? That nobody should go anywhere for Thanksgiving, that getting a test ahead of time is not helpful, basically sit home in a room by yourself. And what I would argue is that what we need is an alternative point of view. So, for example, in my family, we're getting together with my two boys. They both work at home up in Austin. They don't go out. They basically haven't been socializing. They get everything from Amazon or Costco online and delivered to their house. And so, we're going to have a quiet Thanksgiving together. The reality is that anything you do is a calculated risk, right? There's no 100%. So if you're going to fly somewhere, that means your risk is higher than if you don't. Or if you take a train or any type of mass transit, that means your risk is going to be higher. If you get a test and you're negative, what that means is that when you got that test, you didn't have it, but it doesn't guarantee that you won't get it somewhere along the way. But still, it's probably better off than not getting a test, right? So there are some family groups that are doing that. There's some family groups that are getting together in large groups, but they're having everyone stay far apart. They're having meals outside. My best advice is, what you're ever thinking of doing is just scale it down. Again, in my family, we've had several other people that said they wanted to come, and we said, okay, you got to get a test. And they go, I don't want to do that. So, that kind of selected some people out. And so it's just going to be a small group. And is it going to be perfect? Absolutely not. But it's very important that people be thinking and looking and seeing what's going on and avoiding those situations that, as you do get together, that would put people at high risk. And it's also important that if I am worried that I might have COVID, one, I should get tested, and two, I shouldn't expose other family members to it. So that's why I say, please don't do that to grandma. If you're going to go visit your grandmother, make sure that everything's going to be okay, because it's likely that she's the one who's going to have the bad problems, not you. So think about other people as you're making your plans.
And that's been the one consistent, man. I think it gets lost. And I want to bring it, because you've said this from day one. This isn't about necessarily your health. It's about the health of others that we're talking about. That for some people, if you have been exposed to COVID-19 and you happen to go around other people, that for some people that turns out to be a death knell for those folks. And I'm sorry, one of our viewers, I was looking over to get another question, and I'm just going to have to say this. Ben, you just commented, let's just put this to rest for the umpteenth time. The death rate, fatality rate of the flu is not higher than COVID-19.
No, No, it's not. So
That is
no,
not factual. Never has been factual.
no.
And as I say, it's these conspiracy theorists on this particular topic are just the numbers prove it. It's not true.
250,000 people died from COVID, and since January 20th in the United States, 175,000 people died from the influenza in the last 5 years. So it's about 4 to 5 times more deadly than influenza.
Yeah, it's just, it's amazing that that particular subject just keeps sticking around, and is just. I was going to say, I'm an editorialized. It's idiotic. So I'm sorry, folks, but anyone who thinks that, listen, I get anything else we're going to say. Listen, I want to spend time with my family. I want to be able to do this. People who go to either extremes on that, that's fine. But when you try to say this is a hoax and this is a lie, I can just tell you, as somebody who's been covering this and seen people affected with this, Dr. Keiser as well, we're not here to BS you. We don't get anything out of that. I'm not sure what y'all think about that, but anyway, just, I'm sorry I got on my soapbox there, but it's just an idiotic comment. It's an idiotic falsehood, and I'm just not going to allow that to go in while we talk about that. However, getting to what someone else asked, is that and it's a great question here, and I want to thank our viewer Meredith Rue, who asked this question: is how about for children on the vaccine? Because a lot of times vaccines that work for adults have obviously that's the first round of kind of testing stuff. Is there anything specifically being done vaccine wise for children? And most of the time what we're talking about is preteens and younger when we're talking about this.
So they're starting the trials right now, but is this first round of vaccine going to be for children? No. It's only been tested in adults. They're only going to let us use it in adults, and we have no data that it works in children. The studies are just starting. So what that means is that at the rate at which we're going, you can probably expect news for children to be 3, 4, maybe 5 months away.
Yeah, but at least it's out there.
It's out there, right?
We don't hear that news, and I think a lot, too, as we talked about children being less likely, not immune to it, but less likely to contract or be ill from COVID. And that gets me to the kind of the school situation, because we're hearing a lot, obviously as we see uptick and the like, I found this kind of interesting a couple of weeks ago when you pointed out that schools in our area particularly have been doing a really good job. There have been isolated cases, but almost all of those cases in which there's been a COVID-19 positivity and outbreak is an outbreak has been that it's been localized and not coming from the school setting, but coming from at home or outside the school setting. That really, that the school settings, when done properly, have been more secure than folks' own homes. So that's been, and I just wanted to take on that as we get ready to go that Thanksgiving break, as students go on home, college students too, by the way, and then return back to class. Is that a concern though, even with the protocols that are in place right now?
Yeah, sure. It's something we're actually going to take another look at this tomorrow. In terms of our numbers here in Galveston County, but through last week, what we were seeing was that we were seeing a fair amount of cases in schools. Maybe about 20, 30 cases a day from the schools. Most of them were not transmission within schools, as far as we can tell, and most of them are actually transmission from home. So, and that just reinforces what we're learning. Is that most people get infected from home. Someone goes out of the house, comes in and gets it, and then the majority of the household's infected within 5 days. So what that means is that someone goes out on Thursday, gets COVID, brings it home on Friday. By Tuesday or Wednesday, the next day, most people in the house have it. That's how quickly it can spread within a household. So that's the first issue. But we have seen outbreaks. outbreaks, and we've seen outbreaks at sporting events, and we've seen outbreaks in specific classrooms. And we felt like the schools have done a really good job of trying to get their hands around this and control it. We just had a meeting with the schools again on Friday, going over all of the procedures and making sure that everybody was on the same page and doing the same thing. And we're actually tightening up a little bit on the sports a little bit. So if you have one case, we'll do an investigation. If you have two cases, we'll start quarantining people. But if you have three cases and it's on a team, we're going to basically shut down the whole team. Because one of the things we've learned the hard way is that if you have that many, by the time you get to three, all in that one spot, it's probably everywhere in that team. So,
and we're also moving to the more indoor sports now.
And we're also moving to indoor sports, like wrestling season starting.
Basketball, wrestling, volleyball's been indoors the whole time too. But it's moving now, and that's been one of the things as we look on the East Coast, and that's why I asked, because in New York City, the mayor had shut down the schools,
right?
Instead going to all virtual, and there's been a lot of outcry for that. We saw that just even the thought of that being done in Clear Creek ISD. It's become a controversy with the new pick to be the lone finalist for Clear Creek ISD. Folks really don't want to go down that path again, because it has a lot of effect. Not just, and I should point out, it's a big effect on the students. Virtual learning versus in-person learning, particularly when you're basically going from one style to another style immediately, instead of making it as part of a cultural of education, is not as effective. But the other part of it is the economy gets hurt because parents have to stay home from work right now, going back into the workforce, and the like. It puts a drain on resources that are out there as well. There's not daycares as relatively open as they were before. So I mean, there's a lot of dominoes that fall with such a decision. But since you've been talking, meeting with the schools, and while there'll be changes in sports, right now you're not recommending major changes or even recommending a shutdown trigger for schools right now, correct?
No, actually, if I were going to do anything, I would probably scale back a little bit on gatherings in restaurants and bars. Would probably be the most important thing. And again, there's a very good study that came out of New York at the time, and they had their largest outbreak, in April and May. And what they found was that the place that the virus was transmitted the most was inside restaurants and in crowded indoor places. That's the real key: crowded indoor places. And so, we're now up to 75%. Will it get to the point where the governor says we have to go back to 50%? I don't know. If things keep going the way they are, it may be that, or it may go back to 25%. I don't know what he will do. He has said that he doesn't want to put any additional types of restrictions on things. And I hope we don't get to the point where that has to happen.
Yeah. And for those of you, we're wrapping up now with Dr. Keiser. He does have to get on to a call with state officials, as they're going to be figuring out how the distribution of the COVID-19 vaccines are going to work once the approval, because we're getting near. It's exciting in many ways. It's exciting overall, but exciting in many ways. I hate to say that in the middle of a pandemic, we're getting near to this, and the logistical challenge of that, and the fact of where we are at right now is amazing to me personally, of how that goes. Before we wrap up here, yes, I know I promised last week, Dr. Keiser he's a very good guitarist. He's a very good musician. He was going to play, but he ended up in his office instead of at home. So the guitar is not admittedly. I think that we were going to have a little bit of a thing.
Will get you.
You've got a new hit song there, Dr. Keiser. Yeah. But I think but I do promise we'll get it afterwards. Somewhere around the holidays we'll do this again, because we are going to be doing this weekly. Also, too, just a reminder to you folks, and we'll have something out about this later today. Open enrollment you need to get that done too, because that's a really important. Health District is promoting that right now, because the deadline's coming up for your open enrollment period for healthcare. And that's something I want us to kind of dwell on a lot, because this is becoming alarming for many doctors I know I've talked to. Their patients are just not showing up for general stuff. Forget COVID. They're not showing up. You talked about mammograms. I hadn't seen the stats yet, but I understand there's been a significant drop. Usually October, you see a big spike
Mhm.
in the number of women who come in for their mammograms. Compared year by year, it had leveled down. That's a concern because that has long-term ramifications on other healthcare issues. And then we'll take a look at those as well as we get into those numbers. Anything else before we wrap up this week?
No, just to, during Thanksgiving, just everyone, please be careful. I mean, this, like I say, if things keep going the way they are, it's going to be a grim December. You can make a difference, but you actually can make a difference with what you do.
Dr. Philip Keiser, the local health authority for Galveston County, has been on with us here this afternoon. We'll be back next Monday as well with another of our weekly series there. Dr. Keiser, happy Thanksgiving to you and your bride, your boys, and your father-in-law. Just the five of y'all enjoying yourselves. We may get on virtually, I know, with you that day. And just check in on you guys. That's how I'll get my guitar entertainment from you, I guess.
Okay, all right.
He's actually really good, folks. You need to check him out.
I'll get my son to play along.
Yeah, that's right. Your son's a musician as well.
Yeah, he's a very good musician.
Yeah. So good. Dr. Philip Keiser, thanks for coming on. Happy Thanksgiving. Happy Thanksgiving to all of our viewers. And we'll have our continuing coverage of COVID-19, all other issues in our county, continuing here at I-45 Now.